is Erna Sif Arnardóttir. I'm an assistant professor at Reykjavik University in Iceland. I'm very happy to be chairing this important symposium called Telemedicine and Beyond the AHI, which is sponsored by Nox Medical. So this is a 1-hour symposium. We start off with a talk by Dr. Raphael Heinzer called Beyond the AHI, New Biomarkers of Negative Outcomes in Obstructive Sleep Apnea, followed by a talk by Christoph Schöppel named Apps, E-Health and M-Health in Sleep Medicine, and whether this is a real alternative to the sleep lab. Finally, we have a talk by Dr. Jón Skírnir Ágústsson called Nox Body Sleep and Artificial Intelligence in Sleep Medicine. At the end, we will have 15 minutes for a live Q&A. So please note down all the questions and thoughts you're having during the talks so we can have a lively discussion later. All of these talks are related to this very important dilemma our field is facing, is that we need to move the way we are doing our diagnostic and treatment work from the original way of doing things, which was on paper, in lab, studies overnight, everything on paper. And now we need to adapt to the fourth industrial revolution, using all the technology that is available to us to improve the lives of our patients, both for diagnostics and treatment. For example, it is of interest to realize that the 30-second sleep epoch was designed so just because it fit on one sheet of paper, not because the 30-second have any preference over a 25-second epoch or a 1-minute epoch or even a 1-second epoch. So something to consider. I would like to point out this review article that we just published earlier this year in the Journal of Sleep Research. This is from a task force called Beyond the AHI, which is a joint task force from the European Sleep Research Society and the Assembly of National Sleep Societies in Europe. And this paper is reviewing the rise and fall of the apnea-hypopnea index, both a historical review and critical appraisal. So I hope you enjoy reading this paper. And without further ado, I would like to start the talk of Dr. Heinzer.
Ladies and gentlemen, welcome to the virtual ESRS Congress 2020. My name is Christoph Schöppel. I'm professor for sleep medicine and telemedicine at the University Clinic in Essen, Germany. I'm going to talk about apps, E and M health in sleep medicine, and would like you to reflect how these new developments could open up alternative patient pathways in the future. For sure, there are big chances and opportunities by integrating new digital tools in medicine. But are these just unrealistic fantasies that cannot be implemented in everyday clinical practice? Well, let us talk about the current challenges in sleep medicine and have a look whether and how digital tools could support us. We know from current surveys, sleep disorders have a very high prevalence. As seen here, current surveys of German health insurance companies showed that up to 80% of the respondents complained of bad sleep, leading to the headline, Tired Germany. There are only a few sleep medicine practitioners compared to the high number of potential patients, mouse versus elephant. This supply deficit is not only evident in Germany, but worldwide. In this scenario, digital tools may help us. Especially telemonitoring of positive airway pressure devices has evolved in the last years. In the current COVID pandemic, more video consultations were carried out in order to be able to continue caring for high-risk patients in particular. New home-based sensors also enable a better management of patients with chronic diseases such as heart failure. But how to implement this in sleep medicine? Well, in 2017, the AASM published a sleep telemedicine implementation guide. to outline how telemedicine could be used in everyday sleep medical practice. Regarding telemedicine in sleep disordered breathing, studies could show that telemedical management could lead to significantly improved compliance rates with lower termination rates over time. By adding digital engagement tools like apps, patients could participate in their therapies, leading to even higher adherence rates. But how may digital tools help us in our daily clinical routine as we are faced by more and more patients with sleep disorders? Especially sleep apps may have potentials to face the aforementioned challenge. Currently, there are so many apps, and mHealth devices on the market that allow our sleep to be tracked every night. But very few of them are certified as medical products. This means that we cannot rely on whether they are really measuring what they claim to measure. Thus, we cannot use most of the data clinically. However, the more of these tools are validated as medical devices, the more they could support us in our medical decisions. To certify health apps as so-called digital health applications, a legal admission process has been introduced in Germany. The German Federal Institute for Drugs and Medical Devices will be responsible for this process. It will evaluate whether a health app is able to show positive supply effects in clinical trials. This is the prerequisite to be reimbursed as app on prescription by statutory health insurances. Regarding sleep disordered breathing, current epidemiological studies could also show high prevalence rates in many countries throughout the world. Of course, this cannot mean that everyone has to be treated immediately, but we are facing a great challenge. We know home sleep apnea testing or out-of-center testing may facilitate the diagnostic procedure. Most established devices measure different parameters to reflect respiratory flow, respiratory effort, oxygen saturation, pulse, and body position. Considering the calculation of the apnea-hypopnea index, measuring the total sleep time would be of essential importance. Therefore, some of those devices try to estimate sleep parameters, for instance, by activity. The new body sleep algorithm of Knox estimates sleep automatically by using a range of parameters derived from the respiratory belts. We tested this new diagnostic algorithm against the diagnostic gold standard of polysomnography in 128 subjects sent to our sleep lab with suspicion for sleep disordered breathing. I would like to present some of our results. Regarding the total sleep time, we found a strong correlation between the result of body sleep algorithm and the manually scored total sleep time based on polysomnographic recordings. Thus, there was also a strong correlation of estimated apnea-hypopnea index by body sleep algorithm and the AHI values based on our manually scored polysomnographies. But why not directly performing a polysomnography at home to break the existing diagnostic bottleneck? There are even attempts to do like this. For sure, in clinical routine, you will need experienced staff at sleep labs to put all cables on a patient in the right way. But with new design sensors, as you can see here, a simply self-applied polysomnography at home environment could become reality in future. But at the moment, such systems are only used for research purposes. You will learn more about this in one of the other lectures. By adding cloud-based solutions, new patient pathways could be established, allowing treating doctors not only evaluating the findings by remote, but also communicating them to the patients or discussing them remotely with co-treating doctors. This could reduce working load and prevent multiple diagnostics. By adding machine learning algorithms, the diagnostic pathway for sleep disordered breathing could even be more simplified in future, offering an easy and cost-effective access to care. Ladies and gentlemen, thank you for your attention, and I look forward to your question at the end of the session.
Hello, my name is Jon Augustsson and I'm a research manager at Knox Research. Knox Research is an interdisciplinary team of scientists working within Knox Medical. One of our main expertise is applying artificial intelligence and machine learning in the field of sleep medicine. I want to start by pointing you towards this paper, which was recently published in the Journal of the American Medical Association, titled How to Read Articles That Use Machine Learning. This is a nice paper written for doctors and clinicians who are likely to be using machine learning-based analysis without being experts in computer science or engineering. I think it's very important for anyone using such tools to be aware of their capabilities and limitations, and if this reference is the only thing you take away from my presentation, I'm happy. There's a lot of hype around AI, machine learning, and big data, but there's no clear definition of what these words mean. Typically, AI and machine learning are used to describe models, where the model parameters are tuned by fitting known input to some known output. Linear regression is a perfect example of such models, although more complicated models, such as artificial neural networks, get more attention today. AI models are not intelligent in any way, but can recognize complicated patterns and map them onto an output. An example of this could be a deep learning model trained to classify images as having either a cat or a dog on them. If you give such a model a picture of a bird, the model is only capable of classifying the image as having either a cat or a dog on it. The model cannot deduce that bird is neither a cat nor a dog. Let's look at the difference between conventional programming and machine learning. In conventional programming, a programmer enters rules or a program into a computer. The rules are used to process data and generate an answer. The rules can be arbitrarily complicated, but they are generated by the programmer and can, in principle, be understood by a human. In contrast, machine learning, whether it's linear regression or more sophisticated models, is typically based on using an algorithm to infer rules by presenting it with data and answers. This is called supervised learning. This can be a very powerful approach when it's difficult to write the rules to a program or if the rules are unknown. If we stick with the example of classifying images as having either a cat or a dog on them, imagine you have a friend on a different planet who doesn't know about cats and dogs. Writing them a letter describing how cats and dogs look like would be quite challenging. And if you would then send them a bunch of pictures of cats and dogs, how do you think they would fare in following your instructions? It surely would be much simpler just to send a bunch of pictures of cats and dogs and write on the back of them if the picture contains a cat or a dog. And this is what we do in supervised learning. Once we have the model which we trust, we want to use the model to predict the answers on new data where we don't know the answers. In the case of our alien friend, we would now send a stack of photos of cats and dogs and ask him to label them for us. So the fundamental idea behind machine learning is not too foreign to us. Even though the technical implementation of machine learning can be mind-boggling, we currently have tools such as Python and TensorFlow and more, which allow basically anyone to do machine learning. Even if you know only basic programming, you can take the Coursera specialization on AI in medicine and be detecting tumors from 3D MRI scans in a matter of days. And even if you're not into programming, I would still recommend watching the lectures. But since machine learning is so accessible, what separates the good from the great? Well, in my opinion, it is a deep understanding of the tools, the subject matter, the data, and the questions you want to answer. At Knox Research, we are a multidisciplinary team with a background in engineering, computer science, physics, statistics, and sleep medicine. One of our main areas of expertise is to use machine learning to automate manual scoring for sleep studies and to develop novel analysis to apply to the studies. For the remainder of the presentation, I want to share with you some of our work, and since we're here among friends, I will share with you some of the mistakes and challenges we faced along the way. So let's start with sleep staging. I always tell people that sleep staging is the homework example of using machine learning in sleep medicine. In our field, this is the easiest thing you can do with machine learning, not because it's easy, but because the task is so well defined. We know that we have to classify each 30-second epoch into one of 5 classes. We know what signals to use. Human experts generally agree on how to score sleep stages. There is an abundance of well-scored data available, and there are many papers out there comparing how human experts agree. So we even know how to measure success and what kind of agreement we should expect at maximum. After defining the goal, we have to collect data. And the data should be representative of the data we expect our model to be used on in the future. So when I started at Knox 5 years ago, we had a machine learning sleep scoring algorithm. The problem was that the algorithm was trained on data from people with severe sleep apnea. So these people did not have much N3 and REM sleep, so the model could not learn how to score those sleep stages. It almost scored every epoch as N2. So the first machine learning task our group took on was to update the model to the one we have today. When we have good data, we split it into a training dataset and a hidden test set. When making the split, it's important not to have any data from the same patient in the training and the hidden test set, because this can cause the model to learn exactly some patients, and this will cause the validation on the hidden test set to be overly optimistic. A training dataset is further split into training and validation sets, and we use those sets to develop our models. During the development of a machine learning model, we may easily test tens or hundreds of models, so it's common to get a false positive response. This is why we have the hidden test set. Once we are convinced we have a good model, we can test the model on the hidden test set to see if it works well with data it has never seen before. However, the true test of the model comes when people start using it in the real world. A good place to start developing a model is to look at the state of the art. And for sleep scoring, we have the ASM manual, which tells us exactly what we need to do to score sleep stages. The ASM manual tells us what signals to use and what to look for in the signals, such as spindles or K-complexes. But anyone who has scored a sleep study knows that reading the manual is not enough. You need a lot of practice. And this is exactly the reason why we cannot just write a program based on the ASM manual, but need to train a model to do the scoring. A simple place to start is to use a feature-based artificial neural network. We can use the ASM guidelines to determine which features in the signal are of importance. These can be delta power, signal amplitude, or whatever we can think of. We input these features into a neural network. The neural network is composed of nodes, where each node in one layer is connected to each node in the following layer. The network starts with an input layer, where the features are read by the neural network. Then we have several hidden layers, and a classification layer, and the last node chooses the classification results with the highest value and outputs it. The nodes in the layers normally perform linear or logistic regression using their inputs and passing on the result to the next layer. Since the sleep stage of an epoch may also depend on what came before it, we can also change the last layer before the classification layer to a layer which uses what happens in the past to improve the prediction. This is called recurrent neural networks, and they are used, for example, in language processing and other areas where the context matters. If we have enough data, we can also use neural networks to learn to recognize the important features in the signals. These are called convolutional neural networks or deep learning. The nice thing about sleep classification is that we know how well human experts agree on a task. The ASM Interscorer Reliability Program published a paper in 2013 comparing how human experts agree on sleep stage scoring. The results are presented in a confusion matrix where each row represents the sleep stage scoring of the majority of the scorers, and the columns compare how the individual scorers agree with the majority. For example, we see how they agree on sleep stages and what kind of misclassification we could expect to see. We see it's very unlikely that N3 epoch is scored as wake, but it's much more likely that it's scored as N2. This also gives us an idea of what kind of performance we could expect from an automatic analysis. because if we compare a very good analysis to human scorers, we would expect similar results. Here we see the comparison between our machine learning sleep stage classifier below the ASM results. We see that overall the machine learning classifier performs well, and the kind of errors that it makes are similar to the kinds of errors humans might make. As above, it's very unlikely that an N3 epoch is classified as wake, while it's more commonly misclassified as N2. So sleep stage classification is a very well-defined task in using machine learning in sleep medicine. We have the data, we know how to measure success, and it's possible for a human to look at the raw data and verify the scoring is correct or not. Once we've gained confidence in applying machine learning to sleep stage detection, why not use other signals such as actigraphy or breathing to classify sleep? So first off, at the risk of sounding like the ASM police, but sleep stages are defined what is seen in the EEG signals. So if we want to claim to be detecting sleep stages, I think we have to be measuring EEG. However, we all know that there are many things in the body which change during sleep, and these things can help us determine something about the sleep of a person. We know that most people do not sleep standing up. We know that movement is low, pulse goes down, breathing slows down, and there are differences between wake, REM, and non-REM we can pick up on. So we were motivated to try to provide more information from a home sleep apnea test with the aim to increase efficiency in sleep clinics and provide patients with better care and lowering their burden. So we developed an algorithm that we call the NOX body sleep, which uses the abdomen and thorax rip signals and actigraphy to estimate wake, non-REM, and REM. And here we see two epochs of manually scored EEG signals from a PST study, and below we see the actigraphy and rip signals in a larger time period. The manual scoring from the PST is shown on top, and the results from the body sleep algorithm are shown below. We see that during the non-REM sleep, breathing is stable and becomes unstable during REM sleep. And I think people who are used to scoring sleep studies are quite familiar with how different states of sleep present themselves in the breathing signals. From the body sleep algorithm, we can compose sort of a hypnogram. Here we see the hypnogram from the manually scored PST above and from the body sleep below, and we see they seem to agree. But one thing to keep in mind is that since we're using rip signals and actigraphy in the body sleep, there are no established rules on how to verify the correct scoring from the data. But how does it perform? I could show you the results from our own validation, but instead I want to share with you results from the real world, from the group of Professor Christoph Schöbel in Essen in Germany. In their study, they used 128 clinical PST recordings from the NOX A1 device. The population consisted of 79 men and 49 women who had undergone a sleep study with a suspicion of sleep-disordered breathing. In total, they analyzed over 77,000 epochs where the sleep stages had been scored by standard clinical practice using EEG, EOG, and EMG signals. Then, they ran the NOX body sleep algorithm on the data and compared how they agreed. They calculated the Cohen's kappa value of 0.62 and found that on average, the NOX body sleep slightly overscores non-REM and slightly underscores REM and wake. When comparing the AHI, sleep efficiency, and total sleep time between the NOX body sleep and the PST, they found statistically significant correlations of 0.9 for the AHI, 0.7 for sleep efficiency, and 0.8 for total sleep time, and conclude that the NOX body sleep shows strong diagnostic accuracy for the estimation of sleep and promises a more appropriate and cost-effective method for home sleep apnea testing for patients with suspicion of sleep-disordered breathing. Now I want to take a small detour and introduce the concept of the hypnodensity plot. This is a plot presented by the group of Professor Emmanuel Minot in a recent paper. The plot shows the probability of a sleep stage. So what they did was to have multiple human experts score a sleep study and plot the number of scorers scoring each epoch with a certain sleep stage. Here we see the white areas represent wake, red is non-REM 1, light blue is non-REM 2, dark blue is non-REM 3, and black is REM. The figure shows right away when there is a high agreement between the scorers and when there is a low agreement. What is shown on the lower panel are the outputs from an artificial neural network. The neural network's output probabilities and the class which is normally chosen is the one with the highest probability. But by plotting all the outputted probabilities, we see in this figure how the neural network probabilities mimic the human expert agreement. So we thought this was a nice way of presenting the output of the Knox body sleep algorithm to try to give the user guidance to areas where the model is outputting high probabilities or more mixed results. In our implementation, the plot looks like what is shown here at the bottom, and we start showing a bit more details of the model output. Hopefully, this is useful for people to gain better insights into what the model is outputting and can be used to find areas of ambiguity for the sleep tech to investigate and try to see if the model output makes sense or not based on their experience. With this, I'd like to thank you for your attention and sleep well.